Thank you very much. Thank you for having me. I'm always super excited to come and talk about allergies because, as you will find out, I am very, very passionate about it. I didn't really know what to cover, so I've given sort of a broad overview of allergies, and then hopefully I won't waffle on for too long, and I can really hone in on answering your questions. So I just thought I'd share a little bit about my background first of all. So obviously I am a doctor, and primarily my qualification is actually as a GP. And although I am an allergic person myself, so I have environmental allergies, eczema, and my mum now says to me, having listened to me lecture a lot, she sort of says, "Oh, you had an egg allergy when you were younger and eczema." And so we realise where the sort of allergy family history has come from, if you like. And when I married my first husband, didn't even think about that allergic mix, but he also had environmental allergies and asthma. And so then when our first son, Ethan, was born, who is now 16, when he developed signs of eczema and then a milk allergy, which he had anaphylaxis to several times, a nut allergy, I just didn't have a clue. And started this journey of realization about the world of allergy, which if you're allergy sufferers or parents, you'll know what I mean. It's quite all consuming. And I would take him along to all his allergy appointments and say, "Oh, I tried goat's milk with Ethan and he vomited." And the consultant would say, "Well, why did you do that? It's 99% the same protein as cow's milk." And I was like, "I didn't know." And eventually, when he had anaphylaxis that I hadn't realized was anaphylaxis, his consultant said, I really think you should do more training. So when I was pregnant with Gigi, my little one, who is now nearly 11, I went back to university, to Southampton, which is ironically where I trained, did an allergy master's, worked in Southampton Allergy Department for 5 years, and have since set up a private allergy clinic treating adults and children, and have become extremely specialised in allergy, offering treatments for food allergies as one of the only centres in the country that does that. And it all came about because of Ethan's allergies, and all of my children have some sort of allergic disease, and thankfully his food allergies have gone. But I like to think it really gives me understanding as a doctor and a parent as to how this feels, how hard it is to navigate, why things matter to us as allergy parents and allergy sufferers. And also, I think because I am a GP and we like things nice and simple, I'm hoping that when I explain things to others, and I teach a lot, the language I use is quite straightforward and understandable. It's not too scientific. I'm a trustee for Anaphylaxis UK and chair of their scientific panel, and have been the primary care doctor for the British Society of Allergy and Clinical Immunology, which do have good resources on there. And although I am still a GP, I have to say the bulk of my work these days is in education and in running my own clinic. So I'm going to give an overview of what is an allergy, and I'm going to talk about the two commonest types of allergy that we will see, but it is becoming incredibly more complex, really, as we start understanding more and more about it. We'll talk about the different symptoms that people can get so that you can recognize it. Obviously, we're going to focus on anaphylaxis and how that looks and why you can miss it. And then we're going to talk about the adrenaline auto-injectors we have, and the new adrenaline device, I guess it is, the Neffy, which is literally about to come onto the market and be prescribable. And hopefully that'll give you a good overview, and then I can answer some questions. So what is an allergy? So an allergy is a reproducible reaction that is caused by an abnormal response from our immune system. And therefore, our immune systems are seeing something as being harmful when it shouldn't be. So that could be grass pollen, cow's milk, peanut, sesame, bees, all manner of things. And we as clinicians will know it's allergy based on the symptoms that are described, because there are set symptoms that will show themselves. The timing involved, because really for many of the allergies that we recognize, they come on extremely quickly. And it's important, the reproducibility thing. So it happens every time you're exposed, and also how long it lasts for, because actually there are many things that can mimic allergy, and lots of viruses can cause hives, which is that classic nettle sting rash that we see, including COVID commonly causes hives. And so if you've got hives that are over your body for days, that's not likely to be allergy, because you're not likely to be sort of continually exposed to some sort of food that you keep eating and triggering reactions. But often in young children, especially if they've got a fever, it's probably the illness that's triggering them to have hives. And then it looks like an allergy, but it's not. So when we're diagnosing allergy, the history is the most important thing. And then we can do allergy testing, but it really only confirms our suspicions in the first place. When I meet people, they quite often say, oh, I'd love to be allergy tested. And I said, oh, have you got any allergy symptoms? And they'll say, no. And I'm like, oh, okay. In that instance, allergy testing is completely pointless because it's only about 60% accurate if you've got no story. So if you've got no allergy history, actually, we can have positive tests sometimes, but that doesn't mean you actually have an allergy. It just says your body recognizes it to produce a positive test, but doesn't necessarily mean you're allergic. And that's why I'm always really keen that people are very careful when they go on and buy these sort of high street tests, because they can be completely misleading. People always sort of question, well, what is an allergy versus an intolerance? And the definition of an intolerance is a reproducible adverse reaction. So it happens every time you're exposed, and it's not nice, but it doesn't involve the immune system. And that's the key difference. And I think the challenge that people with intolerances have is that because as lay people, we can use it a little bit dismissively and say, oh, they're intolerant to everything. It really overlooks, for those people who have proper intolerances, how significant it can be. And again, there is no one test to diagnose all intolerances, despite that question being asked to me multiple times a day, because it really depends on what are the symptoms that are being described for us then to try and unpick, okay, what mechanism is involved here? What do I think is going on? And so, for instance, if you have a lactose intolerance that you might have heard of, there are different types, but generally this is something that happens for older people, where if you have a lot of cow's milk that contains the sugar lactose, you don't have enough of the enzyme, which is in our gut, to process it. And so when you drink a milkshake, very quickly, within a half an hour to an hour or so, they'll get bloating, crampy tummy pain, wind and diarrhea. And that is diagnosed with a specific breath test to measure sort of how well these things are digested. Whereas other things, like how well you're processing histamine and a histamine intolerance, for instance, there is no test. And what really frustrates me is when you get companies, let's say like the York testing, that claims to diagnose all intolerances and allergies, it's just a complete myth. And what you'll see that they're doing is they check the IgG level, which is actually an immune cell, immunoglobulin G. And therefore, it doesn't even fit with the definition of intolerance. And all the IgGs actually show you is what have you eaten in your diet recently. So there is a lot of misconceptions around allergy and intolerances, which is relevant to you in looking after either your own family or children in your care, because we know from a really good study last year that 85 to 90% of people walking around with the label of food allergy have never seen a specialist, and they're being diagnosed in primary care, so by their GPs. And as a GP, I can tell you the knowledge is often, not always, not very good. And so there are a lot of people thinking they've got allergies or intolerances that don't. But of course, it is not our job in like an early year setting to question that family. You might, if you got to know them, hint that perhaps they should go and ask for some support and testing and a diagnosis. But we obviously have to believe what we're being told. But it's just to give you the wider picture that not everybody walking around with the labels have them correct, not through any fault of their own. So food allergy broadly goes into a couple of categories. So we have one called the IgE mediated allergy, and this refers to your immune cell immunoglobulin E, which we all have in our body. And in allergy, you will have it raised. So let's say you're grass pollen allergic, your IgE to grass pollen will be high. And those are the allergies, when we're talking about food, that give you the symptoms that we will all sort of be aware of. They're the ones that make you swollen, have a rash, vomit, diarrhea, or possible anaphylaxis. The allergies that people don't quite understand enough about are the non-IgE allergies. So they're the ones that don't involve that immunoglobulin E. And a big frustration for families and sufferers is that there is no test for us to diagnose it, because they can't find a pathway to sort of pinpoint, to measure in a lab setting. So we diagnose it based on what symptoms somebody's describing. And then we say, well, take that food out. Do things get better? Yes. Try it again. Did the symptoms come back? Yes. And then you're diagnosing them with it, which, really does rely a lot on caregivers' description, which isn't always that easy to do and unpick. It generally resolves by about school age, but not always. But they still, whilst they're not life-threatening reactions, and neither are intolerances, if you have ever been a parent of somebody who gets delayed allergy symptoms, so the non-IgE symptoms, you will know that it is still life-affecting. And in hindsight, I'm sure my middle daughter Florence had a non-IgE milk allergy. And the symptoms we saw were she was utterly miserable and screamed all day and night. She had issues with her bowels, so diarrhea and then constipation later. She was quite refluxy, so they arch their back. They're not happy. They might vomit. And they get tummy pain, and that's why they're awake at night. And these are young children that can't describe their symptoms. And I just thought Florence was an extraordinarily difficult baby. But looking back, of course she had allergies, because she's also got eczema and environmental allergies, and we've got this strong family history. But it has gone, because it does go in time. But what I'm trying to say is, if in your setting that child is accidentally exposed to cow's milk and their allergies are non-IgE, you might think, oh, that's great, doesn't matter because they weren't at risk of anaphylaxis. But on the other end, you're not now seeing that there's a child in pain, awake, not sleeping, probably got diarrhea, so you're not going to have them back in their setting. Parents are having to take time off work, and it's really difficult because none of us want our children to be in pain. So regardless of the type of allergy or intolerance that is being described to you, it's still really vital that we have good processes in place to make sure that accidental exposures don't happen, not least because they can be life-threatening. And this is just another study really just highlighting the fact that many people who think they have food allergies don't. So this was a study from Europe, and it's quite old now, and of parents and caregivers that were surveyed, 25% of people thought that their child had a food allergy. And I would say that's about right. Many adults and children think they have allergies. When they took a better story and a history, that went down to around 16%. When they did food challenges, it went down even further. And then eventually, compared to sort of statistics of studies and things, really there's around 5% of children that have a food allergy. So it's still big numbers. That means you're going to be encountering children with food allergy. But more commonly, there will also be a big proportion of people who maybe don't have it. As I say, it's not your role to unpick that. It's just giving you a picture of how common you will see this and why. So the National Institute of Clinical Excellence have divided the symptoms for you. And these are very medical terms, so I'll break them down. But they've divided them into the different organ groups. So you have skin, gut, and then respiratory, so your nose and your lungs. And compared the two side by side. So remembering that your IgE ones are the ones that bring you the anaphylactic risk, and the non-IgE ones are the ones that tend to happen in infants and generally outgrown later in life. So for IgE, they get pruritus, means itching, redness. Urticaria is just a fancy name for hives. So like you've been stung by a nettle, the bumpy rashes that come up. And angioedema is swelling. So what classically happens if they've eaten what they're allergic to, they'll get a rash around their mouth, often wherever it's touched them, and then it becomes more widespread. And they might get lip swelling, eye swelling, hand swelling sometimes. The delayed allergies, the non-IgE ones, and I call them delayed because the symptoms don't come immediately. They come 2 to 72 hours after exposure, so it's very difficult. They don't in their own right cause eczema, because eczema is caused because of changes to the skin barrier, but they will make the eczema harder to control and certainly flare it up. So if a child is covered in eczema, it's often a sign that there's a possibility they're going to have allergies. Not every person with eczema, about a third don't, but certainly in a young child, I'm going to have on my radar that maybe this child's going to have allergies as well. And then if you look at the gut, for those immediate allergies, they get swelling within their mouth. They'll often get an itching. So it is interesting. They will often have some sort of food refusal. So they'll say, oh, the food tastes spiky or spicy, or I don't like it, or they'll push it away. And I remember my poor little man would often say, oh, Mummy, it tastes spiky. And food labelling laws were quite different 16 years ago. So it was quite hard to always have checked properly whether it had milk in it. And I'd be like, oh, Ethan, eat your dinner. And then, bless him, he would swell up and vomit. And when I went back to the packet, I would often realise that it actually had something in it he was allergic to. So really hard, isn't it, with younger children, because they can be fussy. And of course, it's our job when we're overseeing lunches, etc., that we're trying to get them to eat. But sometimes if it's that allergy child, tune in if they're not wanting to eat something. Maybe there's a reason. It might just be a warning to double check those packets. They also get immediate onset of tummy pain, vomiting, diarrhea. The non-IgE, you can look at that list and go, God, like there's so many babies that have some diarrhea or a bit colicky. How do you know whether that's allergy or not? Especially because I said there's no test. And you don't really, but it's pattern recognition that these children tend to have multiple symptoms. So they might be refluxy and have diarrhea. And only if they have extreme disease do they start not growing properly, so they won't gain weight and their length won't grow. But that doesn't mean they haven't got severe disease in terms of how much it's impacting their life. But many of them will still grow. So Ethan actually had mixed disease to milk, and he was on the 99th centile. So he was a great big fat baby, but he still had eczema, diarrhea, was quite unsettled, refluxy. And then when he was directly given milk and not just via breast milk, he then had the vomiting, the swelling, and the more obvious signs that there was a clear milk allergy from an IgE perspective. And then for respiratory, if they're allergic to a food and they eat it, they might get what looks like hay fever. So they'll sneeze, congest, itchy eyes. And then if they start coughing and wheezing, those are signs of anaphylaxis. I won't focus too much on the respiratory for non-IgE babies, but they can be a bit grunty. So anaphylaxis, this is one definition of anaphylaxis: a severe, life-threatening, generalized or systemic, meaning full body, hypersensitivity reaction, so allergic reaction. And I say one definition, and one of the big challenges with anaphylaxis is, depending on what paper you read or what country you're in, the definition is slightly different. And I find that in today's society, where everybody's on Instagram and social media, actually, like if you're watching an allergist in America, they're going to be telling you to treat anaphylaxis a lot sooner than we would in the UK. So in the UK, this is from Anaphylaxis UK. It's a nice poster. I think you can get them printed and put up. We're looking for A, B, C symptoms. So A is for airway. And this is the story of poor little Ethan. So he was given ice lolly balls. And like the very bad mother I was, I didn't check the packet because I thought, who puts milk in ice lollies? And he promptly started coughing. And it sounds like you're clearing your throat. So it's like, and he was about 2.5. And he'd also got a bit of a thing at that time that he liked to cough, in my defense. So I said, ew, Ethan, stop being so silly, stop coughing. And it went on and on, and I kept telling him off. And then I put him in the car, and we were driving back from Weymouth. And so because I wanted him to nap, as you all know, don't make eye contact with a child who's trying to sleep. And the whole way home he coughed, and I told him off. And when we got home and I took him out the car, he was extremely swollen, covered in hives, still coughing. And so I was like, oh, check the packet, had milk in it. So gave him antihistamine and his inhaler that we actually had. And he did get better, because one of the things to remember with anaphylaxis is 80% of episodes actually resolve even when adrenaline isn't given. Now, that's not to say we shouldn't give adrenaline, because I should have used his EpiPen. But the reason we don't hear that everybody's dying all the time from allergies, thank goodness, is because we naturally produce our own adrenaline when we're stressed. So when we hear unhelpful terms from a paramedic that's calm, or a lay person saying, if it was 1 second later, you'd have died, that's really unhelpful, because it will hold in that person's memory forever and impact their quality of life. When actually the reality is dying from allergy is very, very rare. It's not to take away the severity or make you not heed. You need to be treating it. But there are around 20 to 30 deaths in the UK from allergy. And actually, when you think about the number of people with bee and wasp stings, medicines, food that they're allergic to, that is low numbers, thankfully. But I didn't realise that coughing was a sign of anaphylaxis. And that was why I got told off from the consultant. The other more subtle symptoms are that their voice changes. So it goes really croaky or absent. The tongue obviously can swell. B is any breathing problem. So if they start wheezing, it's noisy, they're grunting, then, you need to be thinking about it. And C is sort of conscious level or circulation. So an older person might say, I feel really dizzy. Little ones tend to look very pale, go suddenly very sleepy. And that is a real worry. And quite often older people will say to you, I feel like I'm going to die. And that's the release of the chemicals that they're getting into their system. They also might get chest pain. And we also have a kind of D for deterioration. So let's say they've got some hives and you've given some antihistamine to help with that. And now they're swollen and now they start vomiting. There does come a point where you're better just to reverse this reaction and stop it and use adrenaline. So for me, it's A, B, C, and a D if things just steadily get worse. You are never going to be told off for using adrenaline. Or if you do have some clever soul that says, well, I don't think you needed it. Who cares? The person's alive. Adrenaline is extremely safe when used into the muscle. And if there's ever doubt, you should be using it. And the other key things to know with anaphylaxis is that moving around makes it worse. So if they're having breathing difficulties, then they should sit still and sit up. If not, you need to lay down and lift their legs up. You use adrenaline if you have it, ring 999. And the other important thing to say is that you must state that you think it's anaphylaxis. It is the word that prompts an urgent response. If you don't say that and you say they've got allergies and I think they've got breathing problems, you'll go through a triage system and sometimes it's triage wrong. If you say anaphylaxis, it will automatically be categorized to an urgent call. And then if they weren't better after 5 minutes, you repeat the adrenaline dose. And I know there's lots on social media that is actually driven by another charity that it must be given in the other leg. And that is actually a myth. There is no evidence that giving it in the other leg is needed. The same leg is absolutely fine. Of course, there comes a point of that person's going to have a bit of a sore leg. So naturally, you might give it in the other thigh, but it doesn't matter. That's the key thing. It's early intervention that will save lives. So whilst 80% get better on their own, 95% would be better after one adrenaline pen and 98% better after two. And the majority of the rest better with more adrenaline, which will be given by a paramedic when they come, or the hospital. So the commonest things you can be allergic to still are cow's milk, and remembering that cow's milk will actually include all animal milk with the exception of camel milk, but we're not going to give camel milk because it also brings respiratory disease. But cow's milk, eggs, peanut, tree nuts. If you didn't know, peanuts are not a nut, they're a legume, so they would fall in the category of lentils, chickpeas, peas, soya. Tree nuts are things like hazelnut, almond, cashew, pistachio, walnut, pecan, Brazil, macadamia. Pine nut, also not a nut. Coconut, also not a nut. Nutmeg, also not a nut. Woman, not a man. And that's how I'd like to say. Just because it's got the word nut doesn't mean it's a nut. Soya, seafood, and shellfish. And there's an element of there are certain foods that are more likely in children. So most of those happen in children, but actually shellfish is much more common the older someone gets. So adults more commonly get shellfish allergy. Children more commonly get these other things. Now, you may have seen that the top 14 allergens need to be labelled in bold. Now, there are some things that are labelled as a top 14 allergen that in my experience are not really. So things like celery and mustard, they're really not common. I could probably count on two hands in 11 years how many people I've seen with a mustard or celery allergy, but they have got on there. However, these days we're seeing much more commonly allergies to pea. And this is such a problem because it's not labelled in bold. And pea protein comes in lots of food. For instance, Twister ice lollies have pea protein in it. And I've had several children now have anaphylaxis to that were caught out. Some milks, like I think it was one of the oat milks that one of the companies made, I think it was Alpro, they put pea protein in it as well as the oat because probably it was cheaper. And people didn't realize there was a change of formulation, and lots of people were having anaphylaxis to it. And it's because it uses yellow split pea, which is a baby version of pea, green peas, but is high in protein content and was tripping reactions. So it's not quite true that you can be allergic to anything. like E numbers, not common. But again, I go back to, it's not your job to unpick that, but common things are common. And these are the sorts of things that you will often get in settings, along with a few extra bits and pieces. So just to put into context for you a little case. So Flora is 9 and she came to see me as a doctor, worried that her maybe she has a peanut allergy. And she used to eat peanuts really regularly as a toddler, but at some point stopped and hadn't eaten them for years until she tried it again. And within 15 minutes, she had urticaria, so the hives around her mouth, angioedema, that swelling of her face, and she vomited. And when she was specifically asked, her mum said she was coughing and her voice went hoarse. The mum had given cetirizine, which is an antihistamine, and her symptoms got better after half an hour. And she has some personal risk of allergy because she's got eczema and asthma. And these are what we call atopic conditions: eczema, asthma, environmental allergies, and food allergies. And so do mum and dad. And it's that genetic risk I talked about. So the bits in the history here that make me immediately think this child has a peanut allergy is the symptoms involved were hives, swelling, and anaphylactic symptoms. So they fit with what I would expect. The timing. So when people are allergic with the IgE allergies, generally it happens as they're eating the food, but we allow kind of within an hour or two. It very commonly is within an hour. And classically, it's gone within a few hours. So as I say, if you've got this for days, probably something else is going on. And what happened for poor Flora, and this is a very common scenario with children actually, is that we know from good studies that children actually should be introduced to peanuts with using peanut butter or grinding up peanuts because of choking early in life. Particularly children with eczema have a higher risk of peanut and egg allergy forming. So we now are starting to say, look, if you've got eczema and maybe a family history, and when that baby's ready to wean, so they've got to be sitting up, holding their head up, the parents should really think about, from the age of 17 weeks, introducing peanut early. And everyone always sort of goes, oh, you're giving a baby peanuts, it could kill them. But actually, when it comes to allergy, younger children are much less at risk of really, really severe allergic reactions. The riskiest time from your food allergy perspective becomes into your latter teenage years and early 20s. So when we look at deaths, which I stress are rare, there's been one death in 20 years in a baby, and the majority of deaths are actually in 19 to 25-year-olds, not just because they're going out and drinking and taking risks. We don't quite know what happens to their body, but we do know that if younger children can eat them, and then they must eat them 3 times a week till the age of 5, we can reduce their risk of allergy forming from 35% down to 10%. And so it's really difficult when we're all sort of nut-free settings, because for children whose parents have got peanut allergies, who really want them to eat peanut, it's actually really difficult for that family to find a time that they could get peanuts. And an ideal time perhaps would be in a school or nursery setting, which of course can't happen because we tend to be nut-free. And we might touch on that in a minute. So when we're looking at allergies, we will confirm them either with a skin prick test where we put drops of solution on their arm, pop the bubbles. It doesn't hurt. You're just pricking the skin and you're looking to see whether they get a raised hive there. Or GPs can do blood tests. Or if we really didn't know, we would do a food challenge where we give them small but increasing amounts of the food to see if they have a reaction. Remembering this is only for those immediate allergies. These are all sorts of nonsense tests that you will see. So this IgG is this intolerance testing, Vega testing, kinesiology, hair analysis. There is no evidence that any of those are validated allergy tests. Patch tests are different. They're done by dermatologists to look for like chemical allergies, but they're not used for food allergies. So in your minds, you can be thinking, do you think Flora should be prescribed an adrenaline auto-injector? And the answer to that is yes, and her GP should be giving it before she's even seen an allergy specialist. And those are the guidelines because she did have anaphylaxis. And hopefully you may be aware that, very excitingly, we literally just about have a new adrenaline device on the market. So currently we have 2. We have Jext pens and we have EpiPens. And those obviously contain needles. And you have a junior and a senior strength. So when you become around 30 kilos, you will move from the junior Jext and EpiPen into the senior strength. Roughly, that's about the age of 6. But obviously it just depends on whether you've got a small child or a bigger child. And they're great, but there are some issues with them. It is an injection. Children move, and I've seen them scarred all the time from these things. People can get needle phobic. very excitingly, we now have the Neffy. It's called Neffy in America and the Neffy here, which is, I'm told, going to be prescribable on the 20th of October. We have yet to see whether GPs can prescribe them. I suspect the answer to that is not yet, but they will probably come from hospitals first. And this is a nasal spray that will be used up the nose instead of the injections. The Neffy comes as a 2 milligram strength, which is for those who are 30 kilograms. There is a 1 milligram strength for those from 15 kilograms, which will be coming because it has been approved in America, but it will probably hit the UK next year. There are also other exciting things coming, and again, maybe next year, maybe the year after, such as like a dissolvable little tablet that will go under the tongue, which will deliver adrenaline. So it's really important that we start to recognize all of these different things and know how to treat. So I'm going to give you some demos. So first of all, things to say, you can go on all the websites of these companies and ask for training pens. You just fill out and they'll give you they'll send them to you at your home or your preschool or nursery setting. So Jex and EpiPens will come in a case. They will all have expiry dates on them, so you need to check they're in date. Roughly, they last about 18 months, whereas the nice thing about the Neffy is it'll last 30 months. Jext and EpiPen are, what's the word? They don't like heat or cold. They're all right in the cold, actually, as long as you don't freeze them. If they got cold, they would still work. But if they were overheated, then actually the adrenaline degrades. And again, the lovely thing about the Neffy is no worries about heat or cold. It's not going to affect the device. So both of these devices have a window on the real pen, and the fluid just needs to look clear. I have to say, I've never seen it look murky, but it has to look clear. When you are holding them, I always teach you to hold them like you're riding a bike with no thumbs, because the amount of adults that put their thumb on the wrong end and deliver themselves a shot of adrenaline in their thumbs is unreal. EpiPen's got a nice rhyme, and it's blue to the sky, orange to the thigh, whereas Jex doesn't, but it's got a lid and a needle end. And when you've taken the lid off, that's when it's ready to go. Now they go through the trousers, through your skirt, so you don't need to strip anyone off. And I'm hoping my camera works because I can't see myself. You divide the leg into sort of 3, and you're going in the middle third of the leg. Just avoid the seam. Now, actually, as allergists, we will often teach you to hold the pen over where you're going. So hold it on the trousers ready and then firmly press, and you will hear a click on the trainer and the real device. And you're going to hold for an EpiPen for 3 elephants, 1 elephant, 2 elephant, 3 elephants, and then give it a rub. The needle goes inside, so you now can't stab yourself. And for a Jext, hold and press, hear the click, and it's for 10 seconds. The reason we don't teach to swing in is I have seen far too many children that move and are scarred from adrenaline auto-injectors. And one poor child actually had it snap in their leg. So if you get a good firm grip of that child, maybe a cuddle with another adult, and then come to the side and hold and press, it's going to be much more controlled for them. Remember, these are spring loaded, so you'll have a feeling like you want to pull back, but resist it. It takes that length of time for the adrenaline to drip in. The Neffy spray goes up the nose. Now, with a nose spray for adrenaline, you literally are just going to put it in the nose and go straight back. When you have nose sprays for like hay fever, for instance, we tell you to angle it to the side, but not the Neffy. It's going to go straight back. And you don't prime it. So you know how sometimes with a nose spray, you press it a few times to check it's working. If you do that, you've used the adrenaline. It's a one press and then it will deliver it. So you just literally press it and there's a little resistance and you'll hear a click and it will go in the nose. Doesn't matter if they sniff or not, but it goes in that nose. It works very well. It has been shown in studies to have a slight delay in how quickly it hits the bloodstream as compared to EpiPens. However, it still brings about the same benefit, and the real world data that we're getting through when people are using this in practice or in food challenge situations, for instance, is that it is working just as effectively, remembering that there are circumstances anyway when 1 EpiPen or Jext isn't enough and people need 2 or more. It is going to be the same thing with the Neffy. But the nice thing is no needles, perhaps less stress, probably less fear from us about giving a child a needle, and therefore I think it will be used earlier, and in that respect I think it will means it will be more effective. Now, the important thing to remember about the Neffy is when you need to give another one, if you do, you give it in the same nostril, because the blood supply then there'll be more blood supply going to the nose. It will be sort of primed and ready, and it will be uptaken quicker if you do it in the same nostril. Lots of people worry about, well, what if I've got hay fever or they've got colds? They specifically studied it in those groups and showed that actually, because there's more blood flow to the nose when you've got a cold or you've got allergies, it is actually taken up even better. So you don't need to worry. So for most people, it's going to be a great alternative, and you will see it coming through in time, particularly in preschool settings when it comes next year for the 1 milligram strength. It is interesting when you ask parents, because some of them will say, oh, I wouldn't want to give my child a nose spray and try and pin them down. I want to see that I've given an injection. And then there are another cohort that really would, but there are certainly, I think, in the older teens are very keen on having this. And look at the size difference. And you'll just get a little pack that will come with the 2 in there. They don't go off in your pocket. It's wonderful, in my opinion, to have another option. So most children and adults with allergies should have an action plan. And if they don't, tell them that if they ask their GP, they just need to go to BSACI and search action plan, and it will find one for no adrenaline auto-injector, one for EpiPen, one for Jex. And we wait to see when we'll get one for the Neffy. And at the top, they write what they're allergic to. It tells you what antihistamines to use, what EpiPen to use. Parents sign it. If you are a setting that has a spare adrenaline auto-injector, I know there's a bit of controversy with that in early years, then if they sign it, you can use it. Although legally, any of us can give adrenaline if it was given with the intention to save a life. So you can use even somebody else's on somebody who had anaphylaxis. And that came about because of a sad story when someone went to a pharmacy having anaphylaxis, and the pharmacist didn't feel that they could use the adrenaline because it wasn't prescribed for that person, and they died. And so there was a change in the law to reflect that. There's lots of training videos, and as I say, go to the website, ask for the devices. The Neffy, or your Neffy, I'm still going to call it Neffy, comes with devices where you can actually, I'm not going to use this one, but when you press it, it gives you the proper sensation of how it feels to deliver it in terms of the press you need, whereas this one I've got, it doesn't have the click. So I guess my other message are allergies really do have a huge impact on everybody's quality of life. And there are numerous studies showing that it affects people more than you will ever realize if you've not trodden that path. If you think about every single thing you do, you have to check a packet. You can't go to the park without worrying about who's eaten at the park and touch the swings. You can't go to play dates without worrying that you're a helicopter parent and you need to check packets. You worry when you send your child to a preschool or a nursery setting. Are you going to be junk modelling? Are you going to be inclusive and let my child sit on the table with the other children? It's not nice as an allergy parent to have your kid put on another table alone. I know why you're doing it, but actually I want them to be included and for you to keep them safe there. Having some compassion and understanding. And I have to say, even for those with delayed allergies, it still, to those parents, really impacts their life. You would be surprised. Words really matter. Be careful what you say. Don't give the myths out. Please don't say next time it could get worse. There's no evidence of that. Please don't say you've never had anaphylaxis, therefore it won't happen. Also a myth. Anaphylaxis is extremely unpredictable. Please don't say, oh, well, it's only an intolerance. That doesn't help that person who's going to now suffer with symptoms. And, I know sometimes we'll make light of things. Or, I've heard people go to a restaurant and they'll say, oh, it didn't turn them green then. Or, oh, I didn't kill them. Not funny. And I don't think the media help with this because of the number of films with allergy as the punchline is not helpful. Adrenaline is extremely safe. If in doubt, please use it. It really is safe. You are not going to harm if you use it into the muscle of the thigh or into the nose when we get the Neffy. And there's various bits. We do have a Facebook support group. It's been a little bit on pause because it's been hard to navigate nearly 10,000 people and trying to answer their questions, but I'm hoping to get it open again this month to answer questions that people have. And of course, that's our website with more information. You can follow me on Instagram at Dr Helen Allergy, or email if you need us. Right, let me stop sharing and I can see myself again. This is the bit where I'm always anxious that when I stop sharing and I can see myself again, that we haven't had an internet failure and I've lost you all. So
no, you're all good, and we could see you doing your instructions. So for those that haven't met me before, I'm Amy and I work with Tina in Safe and Sound, and I'm going to do my very best to attempt to do a bit of a Q&A here. You've all kept me on my toes by using both the chat forum and the Q&A forum, and we currently have about 350 people on the call. So firstly, thank you for attending, and I will do my very best to answer the questions. If we miss your question, my apologies. And as we said at the beginning, quite a few of the questions are quite personal about your own children's situations. We will try and answer them quite generally, but let's see how we go anyway.
And I'd also say on that, I know not everyone uses Instagram, but I do quite a lot of lives. There are lives saved on there. We talk about these topics all the time. Come and have a listen. Come on to Facebook. We've got lots of expert talks on ours as well. They're a tenner. Some of the money goes to charity. By all means, there is information, and the allergy charities also have lots of fact sheets and podcasts for you to listen to.
Brilliant, thank you. So let's make an attempt, and we will do our best to get through any if we can done in the 15 minutes. And if not, if your question hasn't been answered, just contact Tina at the end and we'll try and collate at least answers from that, either from working through it. So the first one, although Alison, you have just slightly confused me with it. So the first one was a nursery setting who have got a 9-month-old starting at the nursery with type 1 anaphylaxis to latex. And basically, did you have any top tips to support them? And also, is it true that this often relates, they can often also have allergies related to the tree type that latex comes from?
Yeah. Interesting, because actually latex allergies these days are really not common in children. I haven't had a child with a latex allergy for years. Now, it used to be common because in healthcare we always use latex. So if you were a child particularly that had a lot of intervention, like say cerebral palsy in hospital a lot, latex allergies form from that. But because we all now use nitrile gloves that are latex free, I am very surprised that child has
that sort of answers the second bit. So the second bit of Alison's point was actually it looks like the child has medication if he has a reaction, but he's waiting on testing for an EpiPen. So I'm wondering whether he's actually looking, if they're looking.
So the question there is, I have children sometimes who can have very sensitive skin, who can get hives, who parents might make 2 and 2 together and make 5 of like, is this rubber? Let's assume though, because it's not our place to question, that this child has got a latex allergy. So type 1 really just refers to that IgE mediated. It's kind of a scientific way. We don't tend to use it. Yes, sometimes those people have allergies to things like, I think it's banana, kiwi and strawberry. Not super common. Probably much, this is more likely you'd see that in an adult. So I'd ask the parent for clarification, are there any food groups you haven't given, which is probably likely at 9 months? Where is my level of worry? And then really, you just need to approach it in the same way as anything else. But latex is really hard. You're going to have to think about where are we, what in our environment is latex? Balloons, that's going to have it in. Rubber products. I do feel sorry for you. It is a very difficult one to navigate. I wonder if the GP may not, but is there any possibility they would do a blood test for latex to help give some clarity here? Because it is extremely unusual. But otherwise, you do need to look at your setting of looking at what contains latex and understanding that and removing it. Difficult.
Yeah. Okay. I don't know, Alison, if that's helped you. Pop a note if it hasn't, and we'll do our best. And I am, if you asked an early question, partly I'm going to some of the later ones because I think some of the earlier ones, I believe, got answered as we carried on. So we'll go through a couple of hopefully quite quick and easy ones. So this one, just to confirm, because it comes up at pretty much every first aid course I deliver, and I think you sort of pretty much alluded to it at the end. So this question was, I'm a childminder. If I had another child in my care who had an EpiPen and then a child having their first reaction, could I use that pen on child, so child A's pen on child B?
Yeah, you could. And you would be supported in law if you did that because you really felt that there was a reason. Don't forget, pick 999 up. I have a child here that's doing this. I think it's, do you agree? What do you think I should do? But of course, they're not always clinicians at the end of the phone. But if you really thought someone was, yes, you can.
Yeah, and I think that's probably what I know there's a lot of trainers on here like me thinking, so will change what I say because I genuinely believed I needed to use both legs, and that's as a lot of years of A&E. So very nice for you to have clarified that one for me, and probably for quite a few others on the call.
All the studies that were done looking at how effective adrenaline is were always given in the same leg. It came from Natasha's foundation, who do excellent work, but it was at the inquest where they were asked to speculate, the clinician, why did it not work? And the sad reality is we don't know. That was the answer. We don't know. It wasn't because it was given in the same leg.
Yeah. Okay, brilliant. So this sort of answers this, although I know that's a lot of childminders. So one of the questions was, should all settings have EpiPens then?
Good question.
And like, what's a setting, I suppose, is the question.
Yeah, there is a big push for that. I don't think there's a right or wrong. I know the allergy community would love to see it. I think it could be a good thing. Obviously, it's expensive. They do expire quickly. I go back to most people recover even when they don't have adrenaline. We do have good services here. You would get care quickly. I think the spare pens in school initiative is great. I would have said in the early years setting, dying would have been extraordinarily unusual, but I do believe there was a death recently, and that automatically makes everybody very nervous. So I don't think it's wrong. Do I think everybody should? I'm going to just sort of defer and say I don't know.
Yeah,
I think the policymaker can do it. It does have implications and cost and training. Training is what we need.
Yeah, I pinged that one to you because I thought as a group of trainers we wouldn't want to answer that question either. So some of them I think we could answer if we run out of time. So yeah. So this one is a nice one actually, just nice, quick and easy. They've got a 9-month-old in their setting with an EpiPen. Is it still the 5-minute rule for a second injection if needed at that age?
Yeah.
Lovely.
Just keep it easy. When Effie will have a slightly date, I don't know yet. But at the moment, it's 5 minutes.
And with the NFE, the question was they would presume that it doesn't need to be inhaled. It can just be sprayed into the nose because of the age we're trying to think of.
Exactly. And so I did see someone said, do they carry 2? That yes, they'll come as a pack of 2, and you always must carry 2 adrenaline devices.
Is it correct that you must not stand someone up when they're having an anaphylactic reaction?
Yeah, because it drops their blood pressure and makes them significantly worse. And I wrote into a paramedic television program to tell them off about it, but got met with some resistance. But they often do say, walk to the ambulance. It would be nice if you could advocate for them and say, no, look, my understanding is they're meant to be sat on a trolley.
Yeah. But that can sometimes be hard, but yeah, great. Yeah. Nice. Yeah. Is it true that once you have an allergy, each time you have an adverse reaction, it will be worse?
No, that is a myth.
Worded that. Yeah.
That's a myth that it gets worse each time. It's unpredictable. You are more likely to have anaphylaxis if you have something called a cofactor present. So I describe it as the perfect storm. So the more of it you eat, if you're sick on the day, if you've run around just before or after, if you have had ibuprofen strangely, if you're a woman by your period, if you're fatigued, if you've had alcohol, all of those, if your asthma's bad, if you're asthmatic, all the deaths are in asthmatics, you are more likely to have severe anaphylaxis than on another day. It might just be hives and a vomit.
Brilliant. I'm going to guess, so I'm just going to quickly say this so that people can change. The people popping in the Q&A as well were late to join us, and we did say, can you try and just use the chat, so we weren't managing to. So if you've just popped a question in the Q&A, move it or copy it into the chat, because I can't answer both in the last 10 minutes. So we had quite a few questions that were, as I said, were quite specific. But I think maybe if we sum them up, what would be quite a good way for you to maybe just advise or answer your thoughts on? So quite a lot of people are asking, my child has an allergy, they're in various ages, and can we insist on an EpiPen? So I guess probably it's about, this is really where you've already explained the differences between types of allergy.
Doctor, it is very difficult, because I guess the reality is we are an NHS that is struggling from a financial point of view, and these things cost around £180 for two, and they have a shelf life. So there's always a kind of a stratification, if you like, based on the prescriptions. Plus, if you're school age, you need 4, 2 in the school setting and 2 with the child at all times, sometimes 6 if the parents are divorced. And so, and I go back to most episodes of anaphylaxis do self-resolve. And so the guidelines came. We know that deaths, when they sadly happen, they've only been in asthmatics, I believe. And so if you have asthma, that's an automatic. If you've got asthma and food allergies, they should be having it. If they've had anaphylaxis, there's an element of it tells you they're more likely. If they have reacted to trace amounts. So what we mean by that is they've literally touched the surface and touched their face and had quite significant swelling. That's a trace amount. If you live in the middle of nowhere, like somewhere in Outer Hebrides in Scotland, if you're traveling remotely, those are reasons which you can explore. Personally, when patients come to me, even in the NHS, and say, we would like adrenaline autoinjectors because, and you really talk about it, I would like to think that someone would hear you out. There is actually studies showing it actually adversely affects people's quality of life. Their quality of life goes down when you prescribe adrenaline. I know that sounds strange, but it kind of makes it feel more serious. You've got to remember it can be quite stressful as well. But I think it should be a two-way conversation. Can you demand it? I'm afraid you can't. But I think when you try and write your point clearly and use statistics like 50% of episodes of anaphylaxis happen in people who were told their allergies were mild. How can you guarantee it's not going to happen? We as a family feel that we would like it because it'd be nice. I think someone could hear you out.
That was quite a hard one for you to answer. This one I think probably is quite an important one to clarify. First off, so do our I think that's meant to say, should I do allergy medicine first and then the EpiPen?
No.
Yeah.
So the guidelines changed a while ago because what we found is when you looked at audits in A&E, people were never giving adrenaline properly. So don't be put off if an A&E doctor or a paramedic says, oh, you didn't need adrenaline. Just ignore them if you hit the ABC signs. So if you've got anaphylactic signs, adrenaline. Another myth, antihistamines do not stop anaphylaxis occurring. It wasn't that you gave it quick and it stopped it getting worse. It just wasn't either going to happen or it self-resolved. They also don't mask anaphylaxis. They only treat those skin symptoms of hives, swelling, sneezy, tummy pain. So they're good for that. And you can certainly give it alongside, but first line, it's adrenaline. So if they've got inhalers and antihistamine, by all means, give the adrenaline and then top up with antihistamines and salbutamol. But it's not a first line.
Brilliant. Actually, this is one that I've just noticed. There's so many messages, so I'm going to apologise to people now. We are never going to get in the last 6 minutes through all of these. But actually, I've just noticed this something similar. So I'm going to read this one, but we've had a similar sort of comment. So this is really about, and I'm going to guess these are childminders or nursery settings where they have children in their care and they are informed that the parent has a severe peanut or tree nut allergy.
Yeah.
The child's never been tested. So for this particular one, the child hasn't been tested but has eczema, and they are in a nut-free setting, although actually I think the other one wasn't nuts. It was a parent having a severe reaction to something else. Basically, is there any advice, thoughts? This particular person doesn't have an auto-ejector, I'm guessing, in their environment.
So when you're, as a parent, have a food allergy, it's not that you pass on to your child the risk of the same thing. You pass on the risk of A to P, remembering that is eczema, asthma, food allergy, environmental allergy. So just because dad's got peanut allergy, the child didn't have that risk. It could have been that the child has hay fever or nothing, especially if one parent doesn't have any. But if you've now got that child with eczema, as I've said, there is a risk that they might. But of course, we can't preemptively test because that's not helpful. We can't preemptively give adrenaline autoinjectors, but that parent might like to look at the allergy guidelines on preventing peanut allergy and think about, well, could the other parent give peanuts? Should this be explored with a doctor to look at this child's risk?
And actually, the question there was, should they have an allergy action plan? And one of the things, I don't know if this person, I think you probably are a childminder rather than a nursery. And my answer, but see whether you think the same, Helen, is actually that's a conversation to have with that parent of you and the parent together, if you're a childminder, could well develop, because that parent will understand allergies, so we'll be able to
Yeah,
talk you
but
through.
you can't really have an allergy plan if you haven't
And
tried the
for
food
nothing
and
to
you don't
do,
know if
yeah.
they're allergic. And so there is a bigger question of, are you actually inadvertently causing harm? That's a very tricky conversation by not giving it, because obviously you've got to keep the parent safe. But there is an element of that we do need to know for that child. But of course, you could argue this about anything, because you might have a child who never tried lentils and then they have it at nursery because you guys give lots of fancy food that we don't eat at home, maybe. And remember that most reactions are milder in younger children.
Yeah, lovely. Do last couple, and if we haven't answered them, we will collate them and we'll see if we can get you the answers. Do most babies grow out of cow's meat? Cow's milk? I can't speak. You know what I'm trying to say.
Yeah,
CMPA.
milk and egg, yes, commonly by school aged. Although I know people often underestimate milk, but milk is the allergy that we are seeing associated with deaths more commonly than anything else in children, and it is becoming increasingly severe. But yes, they do. In terms of peanut, tree nut, sesame, 15-20% of them will outgrow it. Adults, there's about 1 to 2% of adults with a food allergy as compared to 5% of children, and therefore you can see they do outgrow it.
Fab. I'm going to ask this as the last question, and to all of those that haven't had it answered, I'm really sorry, but we will. I've already noticed quite a lot of them we can easily answer. So, this one actually was, I think you might want to answer as a parent, as an allergy parent. That was why I thought I'd save it. So this is, I'm a childminder and I work from my own home. If I was to get an inquiry to take on a child with a peanut allergy, my challenge is I cannot guarantee my house would be completely nut free. Would it be best for me to say that they'd be better to go to a nut-free setting? Of course, I would try my best to ensure it, but I couldn't guarantee it due to my own family. Did you have any thoughts?
Yeah, and I think also I've seen a few questions of, do we think we should be nut free? And
Yeah,
I
well,
obviously am the trustee for Anaphylaxis UK, and actually we advocate as a charity that we think you should be allergy aware. So there are now obviously there are different situations with families. Like if they've had extreme reactions to tiny amounts, you can understand why they strip their house a bit. But generally, I see a lot more anxiety occur around things like when the parents have fully removed everything, because now you're at school and little Johnny sat next to you eating whatever they're allergic to. Let's say it's not peanut and it's now kiwi. That heightens their anxiety. And there is also an element of they start letting their guard down, because I've been the stupid parent, even though I've had a child with allergies, that sent their child to school with a Nutella. No parent will remember it every day if you're not living that life yourself. And you cannot guarantee that school is nut free or that nursery is nut free. So if we are aware of allergies and, we don't share food, it was a great top symptom because really old, the teacher had a peanut allergy. We don't share food here. This is what allergies look like. We don't bully around allergies. I actually get very upset with nurseries and early years settings when there is a lot of discrimination that goes on, because you get very, very anxious parents. You know what they're like anyway when they start schools and nurseries. They're already stressed to the hill. Add in food allergies and the stories they see and will my child die in your setting, they're going to be putting that a lot on you. If you meet them with a collaborative conversation of what is it that you would need us to do, you don't need to have no nuts. None of us could guarantee any setting anywhere is completely allergen free, but maybe you don't serve peanuts while that child is in and you look for alternatives. So I think ask for support of how you can help them. Understand their stress levels are through the roof, and that's why some people come across as abrasive and rude. But actually, if you can meet them, they'll come down and they'll really be grateful.
lovely, thank you. And I think that's probably a really nice, like the point a couple back that you made of this isn't necessarily about always making a perfect environment, because that's impossible. It's about understanding, education, training,
Yeah.
being aware, recognizing. I think we will have to draw that to a close. We've got a lot of thank yous coming in, so that's brilliant. For those of you that didn't have your question answered, we will collate them. Dr. Helen has very kindly agreed that we can share some of the PowerPoints, and yet, as usual, the recording will be shared with the recording will be shared as it always is. And what we will do with these questions is just draw off all of those Q&As and make sure from the PowerPoint and from the questions before and from Dr. Helen's other advice that we have answered the questions for you. So thank you all so much. We will close it. By all means, drop off. Thank you for giving your time this evening. Thank you very much on behalf of all of us to Dr. Helen, because she has given this time of her own time for all of you. So thank you all very much.